of the Nigerian Society of Anesthetists. Today, we will be having a presentation that defines who we are as anesthesiologists, as perioperative physicians. We have Dr. Emmanuel Auchi-Edafe, who is a fellow of the College of Physicians, cardiology fellow of West African College of Physicians, and also a fellow International Cardiology, Apollo Heart Institute, Delhi, India. And he's a lecturer, Department of Internal Medicine, and in the Faculty of Clinical Sciences, University of Port Harcourt. He's also an honorary consultant cardiologist, the University of Port Harcourt Teaching Hospital. Now, before we allow our esteemed speaker to take the stage, let me remind us of our in-housekeeping. As you join, please, you stay muted until you are asked to do so, or when it is question and answer time, you will raise your hand and then you are allowed to unmute and talk. We also we also have the presenter will talk for like 40 minutes, and we give 15 minutes or so for question and answers. And as usual, we also recognize very senior colleagues here, or colleagues that are occupying important positions in our practice, to say one or two words. Then there will be some announcement from our honorary PRO, and also the President, Nigerian Society of Anesthetists, will give a closing remark. Okay. So Dr. Emmanuel Auchi-Edafe, I hope I'm pronouncing it very well. You have 40 minutes to present, and then we'll follow up with a question and answer. Thank you very much, Doctor. I have the floor.
To be with you today and discuss some of the key issues around perioperative arrhythmias. I'm grateful, so I just want us to start straight. Trying to see, okay. So we may use this outline that is introduced here. We'll look at the definition of perioperative, then look at also the introductions as we move down through the conclusion in the next 40 minutes. So by way of definition, perioperative period is the time lapse surrounding the surgical or the interventional act of a patient. The surgical act can be done in the theater, and it also can be done in the cardiac catheterization laboratory, and sometimes it can also be done by the bedside or any other side choose for that surgical act to take place. Now, the perioperative period is divided into 3 periods: the pre-operative, before the operation, and during the operation and after the operation. And in most of these 3 key periods, the patient is kept in the intensive care unit, or in the coronary care unit, or in the surgical care unit. And from there, he moves into the operation and return back and is being discharged from there. So one of the key things that happen that everybody try to avoid in the perioperative is complication. And one of the key things that will lead to an operation and a complication in perioperative is arrhythmias. So any arrhythmias, which we know as normal arrhythmia, any arrhythmia that occur, and if those arrhythmia occur in this perioperative period, we describe them as perioperative arrhythmias. So The arrhythmia that usually occur can be arrhythmia that's a result of origin of from the conduction, or as a result of rate issue, or as a result of reading, or as a result of the conduction from the SA node into the Purkinje fibers to depolarize the ventricular muscles. Now, it can also be divided as a lateral arrhythmia if it presents as sudden cardiac arrest or sudden cardiac death, or non-lateral if they present with syncope or near syncopal dizziness or palpitation. Example of lateral arrhythmias are usually things like ventricular fibrillation, polymorphic ventricular tachycardia, or asystole, or what we describe as pulseless electrical activity. All these are arrhythmias that are not very good. So the perioperative arrhythmia could be picked up by the anesthetist by knowing how to interpret the ECG, or how to look at the ECG monitor and see what the monitor reading are. It would be very helpful to pick them up during this period. So most perioperative arrhythmias are usually benign without any significant hemodynamic consequences to the patient. But some of them, you encounter them, you need to resuscitate the patient, and you need to do something otherwise. If not, that patient may be lost. So the incidence of perioperative arrhythmia varies. It depends on what you use in studying it. If you use a resting ECG, you will get a different incident. If you use a 24-hour Holter monitor, you get a different incident. If you use the cardiac monitors that are in the ICU, in the cath lab, in the theater, in the operating room, you also get a different incident. So depending on what you have, so about 70% of patients subjected to general anesthesia for various surgical procedures may have one form of arrhythmia or the other. So, it varies from what type of surgery that is being done. Is it a cardiac surgery or not cardiac surgery? Cardiac surgeries usually have more of the arrhythmia compared to the non-cardiac surgery. So as I said, I've talked about the monitors that you use. So it can be as high as 70% in the people with structural heart disease who undergo cardiothoracic surgery. We continue monitoring pre, intra, and post-operative period. So majority of the arrhythmias, the commonest form of arrhythmia that we usually see in the perioperative period is sinus tachycardia. The fear that you are going for an operation is enough to raise your pulse, and that will give a patient sinus tachycardia. Then other things that may also be recorded around this period are things like atrial fibrillation and premature ventricular complex. These are other things that consults have been sent to the cardiology team to review and follow them up. The arrhythmia can lead to an increased perioperative mobility and mortality. Now, also tachyarrhythmias may also predispose the patient to hypotension and secondary reduced cardiac filling and reduced diastolic dysfunction. So increased heart rates may also have some issues with the myocardium, and will lead to increased myocardial demand and also ischemia. Now, bradyarrhythmia may also be a problem, because during bradyarrhythmia, the stroke volume is reduced, and that may bring an issue to the patient to further worsen the patient, depend on the anesthetic agent that is being used, things like propofol, which can precipitate some of these arrhythmias. So the loss of atrial kick in patients with atrial fibrillation, because atrial kick contribute about 20 to 25%, But a patient who has an atrial fibrillation, that volume is already lost into the ventricle. So loss of atrial can also increase pulmonary pressure and leading to diastolic dysfunction. Now, the issue about perioperative arrhythmias, they usually occur because of the changes that occur in the sodium, potassium, and calcium channel, and also in the adrenergic activity that are all targeted in the heart. If we look at the normal activation of the heart comes from the SA node, and the SA nodes generate the impulse, and the impulse transmitted into the atrium via the bundles, like we talk about the Bashman bundle, the Wekichen bundle, and the bundle of Fiore. So these carry the impulse into the left atrium and the right atrium, which depolarize this region, and they converge at the level of the AV node. And at the level of the AV node, there is a slight delay of 0.1 second. Now, that slight delay now make the atrial kick to happen, and the ventricular filling is done, and ventricular contraction starts. And we can divide this into phase 1, which is the repolarization, phase 2, which is the plateau, phase 3, which is tried to be maintained by the potassium, then phase 4, where we have a spontaneous depolarization occurring again. So for the ventricular muscle, you have phase 0 that is controlled by the sodium rapid sodium challenge that open, and then phase 1, phase 2, phase 3, and phase 4. But for the SA node and the AV node, what we have there, we have phase 1, we have phase 0, phase 2, and phase 3. That is what you have there. You never have phase 4, where you have a repolarization occurring within that region. So there are various factors that will predispose a patient to develop perioperative arrhythmias. These factors can be picked up as at the time the patient is being reviewed by the surgeon, is being reviewed by the cardiology, and also being reviewed by the anesthetist. So this, for those that have obvious heart disease or ischemic heart disease, or known to be having ischemic cardiomyopathy, or those who had heart failure or electrolyte imbalance, they are more at risk of developing this preoperative arrhythmia compared to those who never had any of such. So also things like hypoxia, if you think that the patient may be predisposed to hypoxia, hypercapnia, these are all things that will make that patient to develop some of this arrhythmia compared to those who never had that. So these factors, we can group them into patient-related factors. Those are related to the anesthetic factors, then surgical-related or interventional-related factors. Now, for the patient-related factor, we have talked much about them. People who had already existing cardiac disease, they are prone to have this have arrhythmia compared to those who never had. Then those who also have things like intracranial disease, subarachnoid hemorrhage, or who have abnormal ECG finding already, they also tend to have more of this arrhythmia compared to those who never had. Then all those older age group, those who have a background atrial fibrillation, and those who have already degenerative disease, then also the type of surgery that will be done. That, I think that will be discussed under related, surgical related cases. Then for the anesthetic related cases, during intubation, one of the most commonest cause of arrhythmia during intubation is during the preoperative period is when you are intubating the patient. That's when you pass your you call it again? When you pass your laryngeal tube, yeah, when you pass your laryngeal tube, the patient may have arrhythmia. So then also when you are going into the general anesthesia, so during that period, you give your medications, you give some IV, then you calm the patient, you give oxygen. I am not an anesthetist, but I'm a cardiologist. During my young days of posting, I think this is what I see guys in anesthetists does. So you put the patient on oxygen, you bring in, and later the patient went into a stage, then you intubate and you maintain your intubation for that period. During this period, there may be change in the sympathetic activity of that patient. And when there are, they may predispose that patient to arrhythmia. Then also the drugs that you use like halothane and fluoride can also predispose this patient to some of this arrhythmia we are talking about today. Then I do a lot of pacemakers, and I have encountered some of these arrhythmias too, like local anesthesia. For a pacemaker, if you are taking a pacemaker, you just take your lidocaine and you infiltrate. What I usually teach my residents and also those who are learning the procedure from me is that when you bring your 2% lidocaine, don't you put it in the pot, and you have to dilute it so that you reduce it to around that 1%. And that will help in reducing the event of arrhythmia for a patient who already who had a symptomatic bradycardia. So I usually tell them that. So what I do is to reduce those events, I bring the 2%, dilute it with normal saline to reduce it to 1%, then infiltrate and take my access, then infiltrate gradually. I don't infiltrate all at once. These are all things that I do. Then also, when you pass your pacing wire into the heart, I usually also teach them that for a patient who has a complete heart block already, there is atrioventricular dissociation. And because the patient has atrioventricular dissociation, you don't need to pass those wires into from the subclavian into the supraventricular into the right atrium, then go down into the IVC. You don't need to pass those wires into the IVC. The wire needs to stop at the level of either the mid right atrium, because if the wire moves into the IVC and the heart contracts and your wire keep hitting on the wall of the where the IVC make contact with the heart, you can generate a rhythm. And if you generate any rhythm of that point, that patient goes into a systole. So I usually tell them all this, because if you do that, the patient will go into a systole on the table, and it is iatrogenic systole. So you should avoid that by not allowing such things to happen. Then electrolyte imbalance, this can be picked up when the patient is being investigated, knowing what the sodium is, the potassium is, because a patient who has electrolyte imbalance, they will be at risk of having arrhythmia. So the other surgical related things like if a patient is doing cardiac surgery, you are making contact with the heart, you also make a incision in the heart, all these can make a patient generate arrhythmia. Then, or a thoracic surgery where you work in the mediastinum, maybe you're operating in the superior mediastinum, or you're operating in the posterior mediastinum, you need to shift the heart, which is in the medial mediastinum, to a corner so that you can have a good feed to operate. Those contact with the heart can also generate arrhythmia. Then, and when you are doing that, the vagal nerve passes through down, supplying the upper part of the gut down into the middle part of the gut. So while you are doing that, while you are pushing that to allow you get a free operating window, you may also predispose that patient to some of these arrhythmia we are talking about today. Then the non-cardiac operations, things like you are doing the bowel operation, you also push the peritoneum to a corner. This may also trigger vagal stimulation, which will lead to bradyarrhythmia. Then other things like you want to do TAVI, transaortic implant, which a procedure which interventional cardiology do. One of the fiercest complications that we get from such is people we developed either second or third degree heart block, because once you implant that the valve or at the aortic opening for a degenerative aortic valve disease, which results into stenosis, the valve put a pressure by the side. And you know, these bundles run very close to that region. And when there is a pressure on them, a patient may come down with complete heart block or MOBI type 2, which will now result into another intervention to sort that out. So let's look at the sinus, the conduction blocks. First of all, the sinus bradycardia. For patients who had a sinus bradycardia, the first thing about it is that how do we know it's a sinus bradycardia? One, the heart rate is less than 60 beats per minute. Then two, for every QRS complex, there is a preceding P wave. So there is a P wave before every QRS complex. But when you count the RR interval, you will notice that the heart rate is less than 60 beats per minute. Now, it depends. If the patient is not symptomatic, you may not do anything. The patient can, and also it depends on the surgery that that patient is also undergoing. The patient is undergoing minor surgery, you don't have to worry. And if the patient is not symptomatic, you don't also have to worry. For a patient to be symptomatic with symptomatic bradycardia, that bradycardia has to be less than 40. Now, most time when a bradycardia is less, when a heart rate is less than 40, if you investigate the underlying cause by doing a 24-hour, you will notice that apart from the patient presenting with sinus bradycardia, there may also be other readings that present at various times of the day, things like MOBI type 2 or intermittent AV block. So when I receive a consult from the surgical colleagues or from the anesthetist to look at a patient who is going because of the EKG and the patient is going for surgery, we have to, once we pick up something, we have to further investigate to see whether that can lead to more issue or not, which we will discuss later on. Now, for these are also other things that we look at for a patient who had bradycardia. People who had the initiation of vagal or Bezogeris reflex, there is psychological stress, pregnancy, hypovolemia, spinal or epidural anesthesia can also predispose them to have all this bradycardia. So as I said, most time you don't treat the bradycardia because they are asymptomatic. Just follow them. For those that are symptomatic, you can give a very short dose of IV atropine. You can start with 0.5, but don't give more than 3 milligrams for a total of dose of atropine. Okay, now a patient may also come down with a 2-to-1 AV block. This is what you just see like this. And if a patient comes down with 2-to-1 AV block before the surgery, if it is pre-operative, you have to investigate. One is that 2-to-1 block, is it symptomatic? Because where we need to act is to act when the patient is symptomatic. Then two, what type of surgery that patient is undergoing. So the 2-to-1 block can, it can appear that way. Then also remember first degree AV block. In first degree AV block, all the impulses moves from the AV node into the ventricle, But the only problem that the patient had is that the notice that their AV node, it may be around 230, 250, but if they are not symptomatic, you don't really do anything for them. Then for a second degree AV block, there are things we look at for second degree AV block. Now, if the second degree AV block, is it type 1 or type 2? That is Moby type 1 or Moby type 2. Now, if it is Moby type 1, the block is usually within the AV node, within the compactor region of the AV nodes. That is where the block is. And the QRS complex are also narrow. So if the patient is not symptomatic and the echo also show a normal structural heart without any problem, we don't usually do much. We just follow the patient up. If they are going for surgery with quick arm, we follow the patient up. If the patient is in Moby type 2, Moby type 2 is a more dangerous type of block. And the issue here is that the QRS complex in Moby type 2, you see that they are constant. The PR interval is constant, and suddenly there is a drop. So if you get that and the patient is going for any major surgery, first is that I usually advise that you correct that that block so that the patient doesn't have a problem. But even though you correct it, you will still have to check whether the patient is pacemaker dependent or not pacemaker dependent. That is, we will discuss it as we move further. So this is first note. Yeah, Moby type 1, where you have a progression in QRS complex until there is a drop. Then it progresses again. So this is Moby type 2, where the PR interval is constant and suddenly there is a drop. It can easily degenerate to a complete heart block. So sometimes if the patient is going for major surgery and you know the patient is not symptomatic, you just get a temporary pacemaker ready, and if there is a need, you can just pass it immediately. What I usually advise is that get the temporary pacemaker ready, have your access ready, but you may not pass the temporary pacemaker, or you may pass it and just keep it there. And when there is an issue, you triggered it, the pacing, and you come out of that problem. So I've talked about this. Is this symptomatic or asymptomatic? Where if it is symptomatic, you have to address it. I remember a patient who had, I think an 82-year-old man who had a breast cancer, and the surgeon wants to take a left breast cancer. The surgeon wants to do a radical mastectomy. But the patient has a 2-to-1 block, Moby type 2. And that patient is also symptomatic. So when I had a meeting with the surgeon, I told the surgeon the first thing we need to do is to put a permanent pacemaker, because this is a degenerative problem that caused this degree of block here. So we put a pacemaker, and usually we'll put a pacemaker from the left, but for this case, the surgeon is going to do a very extensive mastectomy. So we don't want the device to be affected. So we push it to the right. That gave us an indication that leave the left for the surgeon and take the device on the right. So we put the pacemaker on the right because the patient is symptomatic. After the pacemaker, I told the surgeon, give the patient 2 weeks. The patient was given 2 weeks and the wound got healed, and the surgery was taken. But as at the time of taking the surgery, when I evaluated the device, I interrogated the device, I noticed that the patient still have about 50% of pacing that is still coming from a native reading, because I set the device such a way that you can maintain enough native reading. So because the patient still have that ability to maintain that 50% of pacing. So I told the surgeon that you don't need the pacemaker to be put in VO or put a magnet on the pacemaker. Go ahead with your surgery. After the surgery, we can reprogram the device. And that is exactly what we did. So a complete heart block, the patient has atrioventricular dissociation. The atrium does not communicate with the ventricle. So the next question we ask ourselves here is, how do we identify complete heart block? The P waves are marching on their own, and the QRS complex are also on their own. Then another thing that we also define when we look at a complete heart block, at what point do you have that block? If this block is suprahysia, the QRS complex will be narrow because the conduction that is still maintaining that heart is coming from the conduction pathway. The depolarization that is still maintaining that heart is coming from the conduction pathway. So the patient, you use that to judge. But if the QRS complex are wide, it tells you that the block is infrahysia. That is within the His bundle or lower than that His bundle. That is where that block is. That is why you see that the QRS complex become broad, because it takes a longer time for the conduction system to run around the heart. So if the patient has a complete heart block and the patient is going on surgery, what do we do? The question still remains. What is the pulse of that patient, and does that patient also have symptoms? What is the age of the patient? These are all the questions we do ask ourselves. For older people, usually a degenerative problem that usually causes it. Then for younger people, is it an ischemia or degeneration that happened early enough to catch them at a younger age group? These are the things we ask ourselves. So the treatment is, if the QRS complex is narrow and the patient does not have any symptom, you may not bother with any permanent pacing. You may just follow up the patient. The patient is going for any major surgery. As I said, you have to be around, discuss with the anesthetist, follow up with the patient. Then if there is a need, the temporary pacemaker needs to be put. Then permanent pacing is required immediately if there is a symptom or if there are blood compresses in those group of people, which can easily get degenerated. You need a permanent pacing for them. Then we still have another group of arrhythmia that which can also occur during intraoperative period. We call them supraventricular tachycardias, and they can present in form of atrial flutter, or they can present in form of AV nodal reentry tachycardia, or they can also present in form of a flutter, that is a fast atrial tachycardia, or focal atrial tachycardia, or multifocal atrial tachycardia, or AV nodal reentry tachycardia. That is, either can be orthodromic or antidromic. They can present in all these forms. Let's just take a quick look at them. So for those that are within the AV nodal reentry, they can present as sinus tachycardia if they are coming from the atrium, atrial tachycardia, atrial flutter. Then within the AV node, they can present as AV nodal reentry, AV node reentry tachycardia. Then those that are irregular can be in form of atrial flutter with variable block, multifocal atrial tachycardia, or atrial fibrillation. The management in most of these arrhythmias are similar. So now let's look at the AV nodal reentry tachycardia. For AV nodal reentry tachycardia, it depends on what you are dealing with. It can be fast, slow, fast, fast, slow, and also slow, slow. These are the various types. So looking at the slow, fast, you will look at the V1. You have a pseudo arrow wave in V1. that usually judge the slow fast. You may not see no visible P wave in this group of people. Then if you look at the slow, you also look at that there is one of the key things to identify them. You have a P wave after the QRS complex that usually occur either before the T wave or embedded in the T wave. Usually you see it more at the in V2 or V3. This is where you usually pick it up. Then slow fast, what you usually see among this group of people, just like you won't see any P wave, but you are going to see a depression that's widespread, a fast tachycardia of supraventricular origin with SC segment depression that is widespread through all the limbs. So the treatment here, as we said, is that a patient is unstable, you cardiovert immediately. You do a DC cardioversion, then patient may also be prepared for catheter ablation. Thank God we have a modality of this therapy now in Nigeria. I'm sure we have it in Port Harcourt. Catheter ablation now exists in Port Harcourt and also in Lagos. So we have it now in Nigeria. So the mainstay of treatment, if you have also this group of people, is to give them adenosine. Once you give adenosine, it slows down, it blocked up the AV node, and you will now see the normal reading as you continue the ECG monitor. So supraventricular tachycardia is also one of them. The heart rate is above, the pulse rate is above 100, and the patients, those who have an ischemic heart disease, they may be prone to have more of an ischemia because of if you continue, the tachycardia continue for a longer duration of time. So what we do here is that if you see them, the key thing is to look out for the precipitating factor. Is anything that you can take out to make sure that the patient return to sinus rhythm? That is the first thing. Then second thing is that you can also look at drugs therapy for those who have ischemic heart disease, beta blocker, esmolol. We don't usually have IV IV of this formulation a lot. The most common IV we have is in Nigeria is labetalol, but you use we need more of the beta 1 blockage drugs which are specific to the heart. The IV formulation of them, those are the more of them that you need. But if you don't even have that, you can also give your amiodarone and it also suffice. So adenosine may also be used, and IV beta blocker, as I talk about. If the patient is hemodynamically unstable, you can do a DC cardioversion for such group of people. Then premature atrial beats is also one of the common things you see among patients who have who are in the perioperative period, and regular ECG or monitor, we give all those atrial premature beat. Most time we don't do anything among them, but if you pick up any triggering agent, you can just ask them to take it out. Some of the triggering agent here depend on either they are on the medication or the patient is anemic, or patient is having fever. You just make sure you take out, treat the underlying factors, and they return back. Then atrial tachycardia, yes, it's also seen about 6% of patients who undergo non-cardiac surgery. They may have this atrial tachycardia. Most time it may resolve on its own, but if there is any need, you can use the same medication like the beta blocker to address it. If beta blocker is not available, you can use the amiodarone. So atrial flutter, I want to, because of my time, I want to take the flutter and the atrial fibrillation together. Atrial flutter is one of the arrhythmias that we encounter in the preoperative period, and it may be flutter with variable blocks which behave as if it's an AF. But one of the key things to identify atrial flutter is to look at V1 where you see those saw-toothed waves. That is one of the key things we use to identify it. So if you look at this V1 here, you can see that this is 2-to-1 flutter. You see 2 P waves and you have the QRS complex. So this is 2-to-1 and it's regular 2-to-1. You may have a flutter that is also variable. Now, one of the key things to address atrial flutter is patient is hemodynamically unstable. You do your DC cardioversion. Most time when you do your DC cardioversion, you can start with 50, 60, and you increase it to around 120 to 200. But most time at a lower dose of 50, 60, I usually start around 60. At a lower dose of 60, you do it, maybe you do it once and the patient did cardiovert, you repeat it again at 100. Most time the patient do cardiovert. Then for those that are hemodynamically stable, you can do chemical cardioversion for them on this group of people. You put them on amiodarone or IV beta blocker, they do cardiovert. A lot of them will do cardiovert. But if the patient is on the flutter for a long period of time, you still need to do a transesophageal echo to be sure that the patient don't have atrial clot before, at the appendage before you cardiover them properly. So atrial fibrillation is also similar. It's a problem that we usually encounter a lot in internal medicine world. And one of the key things about it is that the patient who presents with atrial flutter, you need to do their chest VAS score and also heart blood score so that you will be able to know whether you are going to anticoagulate this patient. And you know the problem of perioperative period. You anticoagulate and the patient bleeds. What do you do? Those are the questions we ask ourselves in the perioperative period. So you have to look at the risks and the benefits for you to make your judgment. So these are the various forms of flutter. There is something with, atrial fibrillation. There is something we call a lone atrial fibrillation, which is also, you can find it around people above 60 years of age accidentally, and they may not have any risk among them. So the key thing about atrial flutter is that it depends on what you are anticoagulating with. One of the key things about them is if they have had this for a long time, you have to anticoagulate them. And if you are using warfarin to anticoagulate, especially those who are valvular AF, because the only drug that is approved by the guideline for valvular AF is defined as a patient who has significant mitral valve stenosis, rheumatic mitral valve stenosis, or who has had a mitral valve replacement by way of mechanical valve replacement. So either the patient is on a mechanical valve or who have replaced it and the patient is in AF, or who had significant mitral valve stenosis in AF. So these are the group of people in you use warfarin for only. Now, this group of people, if you put you titrate the INR, which you use to monitor the warfarin between 2 and 3, you can have your surgery and still continue your process. Then you at a point, if you are to discontinue, because of surgery, you want to discontinue the warfarin, you can put the patient on a heparin, because even after the surgery, patient will still be on heparin until the patient return back to warfarin. Then the other issue is that for those that are on that have AF, who are on the NOAS, like rivaroxaban, epizaban, dabigatran, patients who are on this, you can stop that within 24 hours to 48 hours before the surgery. And why you stop it, if you know that the patient will be at a risk of having embolus, you can commence the patient on a heparin, and you titrate a patient on a heparin throughout the period of that time. Okay, so atrial fibrillation, I think we talked about all this. The treatment, I've talked about it. Then there is another group of arrhythmias that we also encounter a lot during the preoperative period. And this group of arrhythmia, we call them ventricular premature beat. Ventricular premature beat, it can come in bigeminy, in trigeminy, in quadrigeminy. Most time, when they occur, what we usually do is to look for the underlying cause. That is what we usually do. Look for the underlying cause. If you look for the underlying cause and you treat it, it disappears. But most time in the elderly, you may not get any clear underlying cause. Sometimes I've seen patients who are bigeminy and their burden of AF is so high, and they also have they also have a dilated cardiomyopathy. We do the coronary angiogram and it's normal. So it's because of the dilatation that created those focal point of scar that is giving rise to all this. So during the preoperative period, if there are no extra risks, and also it depends on the type of surgery, you can go ahead with your surgery, but close eye monitoring has to be kept with this group of people. So this is a bigeminy patient. Okay, so ventricular tachycardia, the management of ventricular tachycardia is clear. You can see that this is monomorphic ventricular tachycardia because the QRS complex are all in, they are all in one direction, that is monomorphic. But you may also have polymorphic ventricular tachycardia. Oh, I was thinking whether I put the ECG of polymorphic ventricular tachycardia. Maybe I put it down. I might have put it or said the point. I will still discuss it. For a patient who has monomorphic ventricular tachycardia, if the patient is hemodynamically stable, you can use chemical cardioversion. You can delay your surgery, use chemical cardioversion. Your amiodarone is there. If the patient has ischemic disease, the drug of choice, even though you may still use amiodarone, is your lidocaine. The lidocaine that we use as local anesthesia is the same thing that we use, the lidocaine. Either you can use that or use the amiodarone. But for a patient with non-ischemic, lidocaine doesn't usually work wonders there. Okay, so if it is not sustained, you may not do much. But for patients who are sustained or who are hemodynamically unstable, you cardioverse them and stabilize them before you take them for the surgery. Then you can also maintain them on the medication throughout the perioperative period to avoid recurrence of the ventricular tachycardia. Okay, so ventricular fibrillation is a lateral arrhythmia, and the treatment is you start your ACLS, defibrillate that patient, do your CPR. So every anesthetist, every working in the ICU must have a good protocol of a CPR for every patient who had this kind of lateral arrhythmia, either presents at ventricular fibrillation or who presents at torsade de pointes. So yeah, this ventricular fibrillation, there is no clear a QRS complex among this group of people, and there is no cardiac output during this for this reading. The patient is dead if that patient is allowed for some seconds to continue on that reading. So what we do is that start your CPR, defibrillate that patient. This is asynchronous defibrillation on this patient, and continue your CPR until a normal reading is picked up. If it is during surgery, you have to, and the patient goes into this reading, you just have to defibrillate the patient immediately, do your CPR, defibrillate the patient immediately, and return back to your surgery and finish it up. So these are the protocol: ACLS immediately, CPR, asynchronous, and also your medication, IV amiodarone, are very key. You can start with your 150 milligram over a period of 10 minutes of amiodarone, then give again another 150 over a period of 10 to 20 minutes. Then as you continue your CPR, your epinephrine may be given also intermittently, very important. So to side the point is very clear. Twisting around the point is also a very lateral rhythm, and which can also present within the period of the perioperative. And if occur, the treatment is similar to what happened. But here is that we should also look out for things like magnesium sulfate. The same magnesium sulfate that you use in treating preeclampsia, the same magnesium sulfate that you can also use to treat to side the point is if there are a magnesium deficiency among the patients. So other treatment is similar to what we said. Correct iron deficiency, if there is any bleeding into the, maybe after surgery, patient is in ICU and the patient bled into, patient had pneumothorax, you have to correct that. Patient have pericardial effusion or cardiac tamponade, you have to drain that fluid immediately to restore all this reading back. So these are some of the doses that we usually give. Amiodarone, I've talked about, because these are the common drugs we use, amiodarone, lidocaine, lidocaine, 2% lidocaine, just tell you that the 20 milligram is in 1 ml of that lidocaine. 1% lidocaine tells you that 10 milligram is in 1 ml of that lidocaine. So that is how you calculate your distance. So if you say 1 milligram per kg and push, and the patient is 70 kg, so you know how to calculate it using converting the percentage to milligram and how to reverse it back. Now, what are the implications for the anesthetists? We talked about local anesthesia. Things like the commonest drug we use for local anesthesia is our lidocaine. Lidocaine for local anesthesia can precipitate arrhythmia if you overdose it, especially in elderly. And because the patient, I usually tell my patient that you give lidocaine, wait a little for it to take, because you give it and you want to take a puncture immediately, or you want to take a knife on the skin immediately, the patient will still feel pain, especially middle-aged and elderly, they will still feel pain. And they feel this pain, you want to keep giving more for elderly, you will end up having problem with the effect of lidocaine. So inhalational anesthesia for induction, also be careful. And as at that time when you are doing induction, put your eye on the patient and make sure that the patient don't go into a rhythm that you can't control. Then drug that precipitates systole like propofol, fentanyl, and suzametonium and vecuronium. These are drugs that also you may use at one point or the other during anesthesia. Then the other things that epidural and spinal anesthesia, when you are giving it, watch the monitor, because remember, once you do that, the patient, you need to preload that patient to make sure that enough volume goes to the heart so that the patient don't go into bradyarrhythmia or tachyarrhythmia. Then a patient who had, maybe you give, who had a systole from epidural or spinal anesthesia, what do you do? As you start your CPR immediately, held down, more fluid to be returned to be given. If there is anything obstructing the IVC, correct that. You can also give your atropine and the patient may recover from it. Sometimes you may end up giving that patient a temporary pacemaker for that patient to recover. Then to avoid tachyarrhythmia, you also monitors if the patient has any autonomic change. Look at, is there pain? Patient is coming from recovering from anesthesia. Is there pain the patient is experiencing? That may raise the pulse of the patient. Is there anxiety? We check for all this. Is there fluid overload? These are key things that the anesthetist should check for. Okay, so the general indication for temporary pacing if you look at the American College of Cardiology General Education for temporary pacing, if the patient is going for cardiac surgery, you may require, depend on the arrhythmia. If the patient patient has a complete heart block and it requires it to be corrected, it's better that that patient is corrected.
Let me bring my charger.
If the patient does not require a need or doesn't meet the requirement of a permanent pacemaker, you can put the patient on a temporary pacemaker while during that period of surgery, and after that you reverse it back. Then there are things that we also look at as an anesthetist or as a cardiologist. There are things that you check, things like if your patient has a pacemaker, you do an ECG. One thing that help you to know is that patient will have a spike. The spike can only appear if that patient has that patient is on a unipolar pacing. But if the patient is having a bipolar lead, you notice that you may not get any spike. So what I usually tell my anesthetists and the surgeon friends is that check for a patient who had a pacemaker, because the pacing goes to the right atrium and the right ventricle. The patient will develop LBB. So if you see an LBB and it's uniform, it's likely a pacing reading. If at all you didn't even see that spike, because if that patient has a bipolar lead, the spike may not appear at all. Okay, so a patient, a pacemaker and a diatomy. So what option we have here during the surgery? So one thing is this, the diatomy may affect the pacemaker function, because the pacemaker may pick up signals, thinking that those signals are signals coming from the heart, and that may affect it. So what you do, if you think that that patient had a unipolar lead, is to program that patient on a bipolar lead. Either you program the patient on a bipolar lead, or you put a magnet over the pacemaker, because when you put a magnet over the pacemaker, that pacemaker is automatically converted to asynchronous pacing. So it paces irrespective of whatever signal is picking up. Then also the other thing also that we also need to know about diatomy and pacemaker is that the use of bipolar diatomy is far better than a unipolar form of diatomy. Okay, so what are the issues with ICDs? Yeah, so what we usually advise is that a patient going for surgery, to avoid inappropriate shock, you deactivate the ICD therapy. That is the first option I usually tell them. Deactivate the ICD therapy, and the next thing is that you put the patient on defibrillation pad, and those pads should not be on top of the ICD, because if the pad is on top of the ICD, one pad fell on top of the ICD, and you happen to defibrillate that patient, you will damage the battery of that ICD. So keep it away from where the ICD is and apply that. After the surgery, then you reactivate the anti-tachycardia property of that ICD back. Then another thing again is that if you put a magnet over the ICD, you also deactivate the anti-tachycardia property of that ICD. And I think these are the key things. So you can shock a patient with ICD. The only thing is that don't put that pad over the battery. That is all that you need to take note there. Then for patients who already had bradycardia, and you give them a pacemaker and they are coming back for another a change of a battery, because once you take out that battery, the patient will return back to the bradycardia. So what you do here is that you first of all interrogate that patient before the surgery. Then when you interrogate that patient, you will know whether that patient is pacemaker dependent or not. If the patient is not pacemaker dependent, what you will do is that you can take out the battery, you reduce the lower rate of that pacemaker so that the intrinsic activity of the heart can take over. If the intrinsic activity is at 40, you can make a change without any problem. If it intrinsic is at 45, there's no problem. So you can do that for such group of people. But for those who are pacemaker dependent, you have to advise that they have a temporary pacemaker on before you take out this battery so that they don't go into asystole once you try to change this battery. Okay, so defibrillators and patients, I've talked about it much that you can put a battery, there is a magnet you put on top of the defibrillator and it deactivates the anti-tachycardia therapy of that defibrillator throughout the surgery. And you just sellotape it on top of it. After that, you remove it and activation comes back. But when you do that, you have to put a pad so that while the patient is on a monitor, if there is any reading that you need to shock, you can easily shock with those disposable pad on the patient. Okay, so the general principle is that it's still there. Correct every trigger that will lead to problem during intraoperative before you take the patient in. If the patient is in heart failure, optimize the heart failure and have a team to discuss. When you have a team to discuss, it solves a lot of problem. It solves a lot of problem. If the surgeon is there, the anesthetist is there, the cardiologist is there, it solves a lot of problem. Then also correct any electrolyte imbalance and discuss with the patients and the patient relative. When you do all this, you avoid anything that will be lateral to that particular patient. So these are some of the medication that may also be used during intraoperative. So to conclude, perioperative arrhythmias are common in our environment. A possibility of encountering arrhythmia at every stage of routine anesthesia practice is high. The patient should be carefully assessed and evaluated with ECGs and other modality of evaluation and correctly being assessed and looked at them carefully and correct any predisposing factors that we increase the risk of developing any of these arrhythmia that we just discussed before taking the patient into any operative process. So the anesthesiology residents should also be given enough time to learn more of this reading analysis and how to use them and interpret them. Then also should be good at BLS and ACLS and renew his license because we have bodies that renew all this license. Renew his license every 2 to 3 years. I think every three years, renews his license and be up to date with his reading so that he will be able to pick them up and act accordingly. So there should also be good interaction with the cardiology team to take a close look at complex ECG. And in that, everybody learn. Thank you very much. And also the patient benefits. So that ends my presentations.
Thank you very much, Dr. Edafe, for this beautiful presentation. Actually, you have spent over an hour, and I didn't want to stop you because it appears every slide you have there is very important. So we allow you to get to the end.
Thank you, sir.
Thank you. And you took us from the definition of what is the perioperative period and highlighted the fact that arrhythmia is a common perioperative complication. And what interests me is that incidence is over 70% under general anesthetic, and that inpatients undergoing, that's for the patients coming for non-cardiac surgery. But you also have over 90% incidence in patients undergoing cardiac surgery. That is very interesting. But another interesting thing for me is he said majority of the arrhythmias are supraventricular in origin. That is really interesting. It's such a broad topic. I'm sure there will be questions and comments. I have a few on the chat box. So please, if you have a question, you raise your hand and then you will be recognized. I can see Laura's iPhone. Please unmute and ask your question. Thank you.
Thank you so much. Dr. Edafe, thank you for the detailed presentation. I think it's a very important topic for us as anesthesiologists to know much about this perioperative arrhythmias. So my question goes this way. If you had a patient that maybe had a CABG, like an open heart surgery, and the patient is in the ICU, and the patient, because usually they place at least temporary pacemakers for them post-operative. So if this patient has maybe an atrial AFib, atrial fibrillation with rapid ventricular rate, or the patient has a ventricular tachycardia, and you gave your bolus immunoderone 150, you gave it once, and then you start the infusion. You run it at 1 per hour, and the patient is now fine. But the pacer now starts kicking. So that means the patient, let's say the pacer was set for 80. That means that the patient's heart rate has dropped below 80. That's why the pacer is now kicking. Do you stop the immunoderone so that you can allow the heart to have its intrinsic rhythm? Because the immunoderone is also part of what must have slowed the heart rate to go below what the pacer was set. Or do you turn off the pacemaker? What do you do? I don't know if my question is clear.
Your question is clear. Very
Thank
good. Yes, we encounter this a lot in the ICU, especially as you said, when you have all this cabbage, which shall now be done in very well in our country. So what you said is correct. A patient who had this, or had a temporary pacemaker, what I usually advise is that you set that temporary pacemaker at 60, because a patient who already have that level of ischemic heart disease, the heart is already compromised. So flogging the heart at a higher rate will further worsen the problem of that patient. For example, a patient who had maybe triple vessel disease and went for cabbage, and that patient also tells you that even though before the cabbage you assess the cardiac status of that patient, even though the cardiac status tells you that the ejection fraction is still normal, I still take it as a pinch of salt, because a heart that is already having so many of that insult can easily tilt down. So I will set the temporary pacemaker at a lower rate. Once the tachycardia is controlled, I will slow down the amiodarone. If you give the 150 and it slows, you give it, then you set up the infusion, and the heart rate comes below 100. What I advise is that you should slow down the amiodarone and watch what will happen, because the amiodarone is good to maintain that heart rate below 100, so that the patient don't have burnt out cardiomyopathy, or more of the heart goes into failure because of continuous tachycardia that is going through. So this is what I advise. You can also even put off that the pacing. You can put it off and look at it. The question is that when you put up the temporary pacemaker, you just see what happened. I will advise that you just put it off immediately, but you slow it down, reduce the rate, and see whether the pacing is still going on. You can put it at 50, then later you put it at 40, then you see whether the native reading will take over. If the native reading take over, then you can just allow the pacing, the wire to be there, but you put it at 40. That doesn't mean that you switch it off. Rather, the native reading is above that level where you set the lower rate. So the native reading is taking care of itself. So if you do it that way, that will be fine. Then once the heart rate drops below 100, you can slow down the amiodarone, slow down the rate. Instead of giving that at every hour, you can increase it to 2 to 3 hours and see what will happen. So these things are not clear cut. Is you keep titrating, main reason to get maximum benefit for the patient. Thank you.
Thank you very much. Thank you.
I hope, Laura, you're happy with the response, with the answer.
Yes.
Thank you. Let me read a few questions on the chat box, Dr. Adafe. You can take them one by one. There's a question on which arrhythmias are absolute contraindications to exposure to anesthesia. And then the second one is what are the indications for placement of a pacemaker devices? Then I don't know, are you taking notes?
Yeah, can I just answer this one before you read more?
Okay,
so
go
that
ahead.
Yes. So the first question says that which arrhythmia is contraindication to anesthesia? Am I right, sir?
Yes, you're right.
Correct. So the question is this. The answer is this. When a patient has a lateral arrhythmia, the lateral arrhythmia, there is no-go area. You won't take that patient to any operating room when there are lateral arrhythmia. The lateral arrhythmias are things that can easily kill that patient. Things like ventricular tachycardia, polymorphic ventricular tachycardia, patient with ventricular fibrillation. You won't take that patient in. You still need to ensure that that patient is stable before you authorize that operation. Then there are other non-lateral arrhythmia like atrial flutter, atrial fibrillation. But if the patient is hemodynamically unstable, you will not also take that patient immediately. You want to stabilize those patients before you reschedule their procedure so that you have a free day for yourself and also for the patient. Then, but if a patient has maybe sinus tachycardia because of perioperative periods, you know, he's afraid and he is having anxiety and the pulse rate goes up, fine, you can intubate without any problem. And the patient thinks once you intubate, everything will normalize. You keep monitoring, everything will normalize. And if a patient has like first-degree AV block, most first-degree AV block, they are not contraindication for anything. That is why if I see it and the anesthetist sent me a consult to look at it and I see it, I usually write that the patient can be taken for surgery if there are no extra risks for his or her age and disease. Why did I write that? I write that only judging by first-degree AV block alone will not do this patient anything, except there is something else we have not been able to unravel in this patient. So that is the meaning of that comment I made here. So if we can't find that thing or that thing does not exist, you can take your patient for surgery. Now, if a patient has a complete heart block, and we always advise the anesthetist that complete heart block should be evaluated. We can do a 24-hour Holter. We can also look at it if the patient is symptomatic. It's a contraindication. Don't go and put a general anesthesia for a patient with symptomatic complete heart block. Once that pulse falls below 40, is reading 28. No, it's not really advisable. If you go into that, you may not have a good response because surgery on its own is a stress. And the patient needs that stress. The body needs to respond to that stress to come out from it. When you make a cut on a patient, you have produced a stress, chemical stress, hormonal stress on that patient. So all those things the body needs to build up to respond. So if there is already existing problem that you know that the body may not get enough within itself to build up to overcome that stress, there is no need. So that is why I usually tell them, if the patient had that level of block, sort out that block, then the patient go for your major surgery. Whether it's a thyroid surgery, whether it's a abdominal surgery, prostate surgery, sort out, or a breast surgery, sort out that major problem. Then you have a free day, you have enough cardiac output to meet up with the demand of the stress. Because once the body is stressed chemically, you need enough cardiac output to meet up with that stress. So these are the ways I usually talk with my anesthetists and surgeon colleagues. Then the other question is, what are the indications for a pacemaker insertion? A temporary pacemaker can be put for a patient who had ischemic disease and is going for surgery, especially when the ischemic disease is also affecting the AV nodes and the patient is coming down with bradycardia. And you know that correcting the ischemia, we correct the bradycardia. So you can put a temporary pacemaker. For example, if I am taking a patient who is right dominance and he had a total block of the ROCA, the right coronary artery is totally occluded. One of their presentation, the patient will come down with bradycardia. Apart from the chest pain, vomiting of right side, the patient will come down with bradycardia. I will first of all put a pacemaker for that patient, because that bradycardia of 40 or thereabout, stressing that patient intervention is not a good thing for it. So I put a pacemaker, then set the lower rate at 60. Then I know that I've covered the issue of bradycardia. Then I will take an access, then take my catheters and wire and open up with PCI and open up the coronary artery. Once the coronary artery is open, that patient will still be left with the pacemaker for a while in the ICU for about 24 hours. After that, I will start reducing the rate of that pacemaker, reducing the rate, then see whether the intrinsic activity of the heart will overpower where I put it. I can reduce it to 50, then reduce it to 45, reduce it to 40, and see the intrinsic activity. Once the intrinsic activity comes up and is being sustained, then I pull out the temporary pacemaker. So these are people that require temporary pacing. Then for those that have a degeneration of the pathway and who come down with complete heart block, and I know that whether you use temporary or you use or you don't use it, the patient will keep remaining in that permanent block. Then the best way is to put a permanent pacemaker. And that permanent pacemaker, once it comes in, then the patient can continue to do any other thing. So there are two major reasons for permanent pacemaker implantation: either AV nodal disease, permanent AV nodal disease, or permanent SA nodal disease. The permanent SA nodal disease usually presents as sick sinus syndrome, which can either be just sick sinus syndrome that presents with bradytachytherapy, or a patient may just present with morbid type 2 or morbid or complete heart block or high-grade AV block. We didn't discuss it. High-grade AV block usually come in form of 2-to-1 block, 3-to-1 block, but most of the high-grade AV block we usually see in our environment, they are 2-to-1 block. So if a patient had this and they are symptomatic, they require a pacemaker. So the commonest reason for a pacemaker is symptomatic bradycardia, which may be from AV nodal disease or SA nodal disease.
Thank you very much. I think I will take one question more from the chat box, and then we allow comment from senior colleagues because of time. The other question probably we take maybe when we send to you, you can share maybe via voice note, and we can pass it on. So
Okay.
this is from Elumelu. He said, so if a patient has an ICD, we should place a magnet over the ICD. Use bipolar diatemy, not directly over the ICD. And also keep your defibrillator pads in place over the chest all through the
Yes, correct.
Okay.
So
correct.
we usually apply we usually implant most of our devices from the left, except there is a reason why you go to the right. If you go to the right and you plant your device from the right, probably you planted from the left and the patient had infection. You have to re-explant the device and you move another one to the right. If you are going to put your pad in this patient that had a device, either a pacemaker or ICD on the right, at just below the right clavicle, what you do in that case, you now put at the apex, you put one defibrillator pad there, one disposable defibrillator pad there. Then in between the scapula at the back, you put another defibrillator pad there. So you will not defibrillate anterior, posterior. The reason is that you avoid putting a pad over the defibrillator, because if you put a pad over it and you happen to defibrillate that patient during the surgery, problem happen and you shock that patient, it will damage that battery. But it's good, as we said, deactivate the anti-tachycardia therapy, because the device may sense things that are not coming from the heart and feel that they are heart rhythm and shock that patient. And if that happens, the patient and also the surgeon operating is at risk. You will get a shock from it. It's at a risk. So to avoid that, you deactivate the device. Then by putting, how do you deactivate? Put a magnet over it, plaster a magnet over it. If I on my this thing, I will show you a magnet. Let me just show you a magnet I'll be talking about. So this is a magnet.
Okay.
Yeah, this is a magnet. There are two here. I show you, yeah. So this is St. Jude magnet. Medtronic also have their own. Irrespective of the company, whatever magnet, whatever company that you have, you can, whatever device you have, you can use this magnet over it. It's not company specific. Once you place it on the device, you sellotape it there so that it doesn't shift, so that it maintains your anti-tachycardia. But if you don't have the magnet, the other option that you can use is you can ask the cardiac technician to deactivate the anti-tachycardia therapy for you. So you put a programmer over the device. If it is a pacemaker, then you deactivate it. Then you move on. But I also said that another role of the magnet is that once that magnet comes on top of a device, automatically it turns that patient into asynchronous pacing. For those that have a pacemaker that are dependent, you need asynchronous pacing for them. So it's either you program them into asynchronous pacing or you put a magnet on top of the device. It also gives the same thing, asynchronous pacing. So once that is done, the pacemaker does not recognize any intrinsic rhythm. It fires pacing all throughout. In order to avoid that, oh, this patient, the device may pick a signal that thinking that it is coming from the heart, whereas that signal is not coming from the heart, and the patient will go into bradycardia that may kill the patient during the surgery.
Thank you very much.
Yes.
Again, Laura is saying that if the patient is prone, where do you place the magnet?
Okay, if the patient is prone,
yes.
Well, before before you allow the patient or you position the patient in the prone position, you put it and plaster it. Once you put it and plaster, it does not shift.
Okay.
That is the aim of the plastering. Yeah.
All right.
It doesn't
Thank you.
shift.
Thank you. Job Otokwala says that central lines can also trigger arrhythmias. Yeah, that is
Very correct.
well noted. Yes. So
Yes.
we cannot take all the questions. There are some questions there. If one of them, if you try to answer, it will be another presentation. It's such a broad topic. We have to, I think I will pass it on to you before we finish.
Yes, sir.
And then
Yes, sir.
when you send it, I can share with them. At
No
this
problem.
point, we normally want to recognize the presence of some notable personalities here and hear their comments. We have Professor Lebe, Professor Lori, Faculty Chair, West African College of Surgeons, Madam IPP Professor Mwaso, Professor Fanfes Ogan, Professor Anis Anite, I think I saw him from Ghana, and Professor Sunday Chineye, the endocrinologist. I've seen him also. So Professor Lebe, please, if you are.
He's my teacher.
Oh, okay, so he's around. He's watching over
yes,
you.
that is great.
So Professor Lebe, please unmute and say something that will benefit us. Thank you, ma. If I'm correct, I've seen iPhone there. I think that is what you use. Okay. Professor Lori, Faculty Chair, please. If you have a comment, please unmute. Professor Lori. Okay, Professor Mwaso, please. Professor Mwaso, you have to unmute.
Yeah, sorry, I was talking without unmuting. Sorry.
Oh, sorry. All right.
Good evening, everybody. Thank you very much for this opportunity, Dr. Alassane Deti Mohammed. I want to thank our speaker for today, Dr. Edafe. He has really gone to town with the topic and really made it very, very practical. I've listened to lectures about arrhythmias and perioperative arrhythmias, and sometimes it's a little bit over the top of the head, but this one is so practical and direct and straight to the point. Thank you so much. You're an amazing teacher and lecturer, and we really appreciate you for that. Thank you so much. My worry or my concern, I was happy when you said that we really need to give more time to the anesthetist to like have direct interaction during training to be able to learn more about these arrhythmias and identifying them and what to do about them. I really agree with that assertion. But I don't know how it can be made to be a little bit more practical, because I know that our residents do have medicine posting and they spend some time with internal medicine, in cardiology, nephrology, GIT, like that. But really, a lot of times there is no practical tutelage about this ECG, arrhythmias general, cardiology generally, and what to do, how to identify them, and the practical things to do about them when we are met on a day-to-day basis with the patient. So I wonder, how can you suggest, or what do you suggest that we do to make it more practical during the training, in the little time, maybe 2 weeks or 4 weeks that the residents have to be in internal medicine, to really put them through, and let it be like across board all over the country, not just in one place or the other, but that every time there's access to the internist or the cardiologist, they can have very good direct hands-on to be able to, handle these problems when we are met with these challenges of these patients that have these comorbidities. That's my own question stroke comment. Thank you very much.
Thank you, ma. Very good. It's good you brought it up. The residents, your residents, when they rotate through us in the cardiology, they spend 2 weeks, and 2 weeks before you know, they disappear, and they are in another unit. So sometimes when I come, I'll say, where is this guy just now? He has left just now. No, he has not learned enough to get it out. So one is that the person who is trained, the trainee must know that he had a very short time to be in that particular unit, and he has to apply himself properly. Because there are trainees that come, you just see them 1 or 2 and you don't see them again. And the next time you will see them is when they will go for exams. So those people, you know, all the fingers are not equal. So I don't know what makes them do like that. But anytime I see them, I usually tell them, if you have to spend 1 week here, apply yourself and ask questions. So if the residents apply themselves and they ask questions, you will get more information from the consultant cardiologists that are coming around to get the rounds and clinics and seeing patients. Then also, for the example, the cardiology team is one that reports this ECG. And you must not learn everything from the consultant. The SR in cardiology, who is in that unit, but for the virtue that he has been an SR for some time in that unit, he has had some skill in ECG. So the learning is from everybody, not only one person. That is the point I'm making. So that resident that is coming for that posting should apply himself at the level of the SR, at the level of the consultant, to learn a lot from them. Then 2, if you give them an assignment to do a presentation around this topic, you will notice that some of them will tell you it's too short. And when they give you that signal that is too short, it tells you that the person is not ready to do any of such. So you just try to be linear with the person and say, okay, what can you do? Sometimes they will deceive you by giving you time. Okay, I'm still around so and so time, not knowing that 2 weeks has elapsed and they have moved to another unit. It has happened to me. They have tricked me like that before. That is why I'm remembering it. Then I see advice that if the college, your faculty can look at it and also increase cardiology posting to more than 2 weeks, like 3 weeks or 4 weeks, sorry, 4 weeks, where more of this ECG, because one of the key things that bridges us together, the cardiology and the anesthesiology together, is arrhythmia issue. Anytime your team review a patient that the surgeon wants to take and you pick up any arrhythmia, you first of all ask the surgeon, invite the cardiologist to come and see. You will not clear that surgery until the cardiology comes to write 1 or 2 things there. So I felt that more time should also be given to it so that the residents can learn more. I'm knowing very well now that these are issues that happen all the time. For example, it is the anesthetists that manage the ICU. The ICU is a disaster place. Just ICU is like casualty. It's a disaster place where anything can happen, because unstable patients are the one that stays in the ICU. That is why they are monitored. That is why they are being extra care is being kept on them. And immediately they are stable, the next thing is that you ask them to move them to the ward where they can be discharged from there. So if more time can be given to this by your faculty, that will be fine, because the residents will learn more about this arrhythmia, then also about BLS and ACLS, and how to identify them and apply those emergency medications on them.
Yeah, thank you very much. I think that reminds me more of a decision we took last year I think every year, Professor Mahmoud Umar Sani, your colleague here in Kano, he gives us a presentation on interpretation of ECG, basic issues on that. Yes. And this discussion came up, and what we, all these things were highlighted, but in the end, we agreed that I think at the departmental level, we're going to allow residents to be visiting the ECG and echo room to learn more. So, but somehow we have failed to do that, and my HOD, Mustafa Miko, is here. I think we will, the next week rota, I think we will put a senior resident there just to take up that opportunity. I think that is one way that we can keep, I mean, they can learn more before they finish. Every week we can put a senior resident to be in the ECG room, and then that way they will learn more. Thank you very much.
Thank you, sir.
Thank you for that. Yes.
Professor Anite, if you are around, please. Okay. If Professor Ilori is still around, please, you can unmute. Okay.
She's no
Professor...
longer around, my president-elect.
Okay, they're not around. Hello?
I think they left. They left already.
Oh, they left. Okay. So let me call on the financial secretary, our financial secretary, Dr. Mustafa Biko, for some announcement. And then after that, Madam President can give a closing remark. Thank you. Dr. Miko? Please unmute. Miko, I've seen your hand raised. Go ahead, please.
Thank you, sir, for giving me the opportunity. The NSA president, on behalf of the Board of Trustees, the Executive Committee, and distinguished members, welcome all the esteemed members that participated in the 9th webinar series, 3rd session, titled Perioperative Arrhythmia, today on 23rd March 2023. You are all welcome and appreciated.
2024.
I also wish, on behalf of the PRO, to announce that there will be All Africa Anesthesia Congress, 13th to 19th September 2024 in South Africa. And there will be NSA Scientific Conference and Annual General Meeting November 2024 in Enugu, the Coast City State. And I wish to remind you on behalf of the Financial Secretary, which I happen to be the one, to kindly remember to be paying your annual dues with the life membership of 200, consultant 20,000 per year, diplomat greater than 5 years, and 20,000 per annum, resident 10,000 per annum, new registration 5,000, and you can pay on the account that we will show shortly after. Don't forget also to be using our NSA social media handles, the Telegram, YouTube, and then this lecture will be on the YouTube after this webinar series. Also, we have our Instagram, Twitter, Facebook, and NSA website, which I will share at the end of this. Thank you very much.
Thank you, Dr. Miko. And when the recording is ready, I will also share again the presentation by Mahmoud Umar Sani, because they go together on a basic interpretation of the ECG. So this lecture will be fully understood. Thank you very much. Madam President, over to you, please.
Thank you very much, my President-elect and Chairman of the Education Committee. Thank you for the good work you're doing. Together with your team members, I want to thank all the various elders present here. Unfortunately, many of them have signed out, and in particular, the Professor Chineye and I can also still see Dr. Tare Ebitonmo, a physician, still on board. Thank you. Unfortunately, his question could not be attended to because he had questions on AI intelligence and perioperative arrhythmias, which I think is a modern trend that should have been attended to. But nevertheless, we would move forward because of timing. We have to allow our Islamic brethren to take time off. So having said that, I would like to sincerely thank Dr. Edafe for this lecture. It's an outstanding one, and I would like to also say that Dr. Edafe actually requested to give this lecture on his own because of experience, because of what he knows, is very vital to all of us. And I think this is an attribute of an outstanding trainer, an outstanding teacher who is generous to impart knowledge. So on behalf of NSA, I want to tell you again, Dr. Edafe, thank you so much. You saw a need and you reached out without being called. And indeed, you have fulfilled that need with this outstanding lecture. Thank you. And
Thank you very much.
Let me say again, to further put an icing on your delivery, you have recommended better training of anesthetists in training. And I must say that in fact, I was going to thumbs up to your last statement on recommendation that anesthetists should spend up to 1 month. And that has been a concern in my own heart, even in my center, that cardiology out of the 3 months being spent by anesthetists in training should take 1 full month. It has always been my concern, my recommendation. Cardiology unit should be 1 full month, and the other 2 months should be spread across all other disciplines, all other subspecialty, all because of this ECG. Like we all know as trainers, and like we all know as residents in training, there is always a slot on ECG question at the exams. And to date, the response has not been impressive. That is, in the answers of questions. Some examiners are on board here. Unfortunately, the 2 faculty chairs were around of National and of West Africa. They have all signed out. But we'll pass it on. I think Professor Sotoye is still here. Professor Samade, past faculty chair, was also here. So I would request that for those of us who remain here, we should cascade this point back home, including that which Dr. Deti has said for his own institution. Yes, that's localized, but we should also take it higher. Our residents should get more in relation to ECG training and cardiology posting, so that we can, because this is the commonest medical ailment we find. Perioperative, there's a whole concept of perioperative medical diseases. Cardiovascular diseases are the commonest. So we need to get the best for our residents. So I think we'll go back and go to the round table and work on this so that we can have a standard setting for cardiology posting for our residents. So on that note, I would like to say thank you once again to you, and thank you for your anchor man whom you used to enter us. That is Dr. Jobo Tokwala, another consultant who is passionate about optimal training, optimal knowledge of essence. Dr. Joe Tokwala, thank you very much.
Thank you so much.
Contributions are well appreciated.
Yeah.
Okay. So having said that, I won't keep you all for too long. It's a weekend where you need to relax this evening. Thank you for keeping time with us. Singapore has been done and dusted. I don't need to bore you any longer with the outcome. We have already posted on the page. God has helped us through, and my PRO, represented by the Financial Secretary, has told you about the upcoming conferences. In particular, please do not forget the NSA 2024 conference in the Enugu Coast City, whose major theme is workforce well-being. Workforce well-being. So begin to prepare your abstracts towards that direction, and then expect the best from Enugu Coast City. Professor Yekulu is also here on board, preparing as Chairman LOC. So thank you to all of you. And
The
I would like to
ICCSN, Madam President, and SAM, their conferences are around June.
Yes, okay, fine, fine.
Yeah.
Please remember those conferences, the ICCN conference, and that is a Critical Care Society conference, and also Society for Airway Management, also pain management. Professor Tonia, I also saw her on board. Thank you very much, Professor Tonia, for keeping a date with us. We appreciate you. That is palliative hospice and palliative care conference, as well as Society for the Study of Pain in Nigeria. So I think on that note, I would like to say you have all done so well. We have been better enlightened, and I wish you all a wonderful evening. I wish us all a good well-being, and I wish us all a good outcome in all our patient management. I must not forget Laura. Laura, are you still on board? Laura, are you still on board? Yes. Laura is one of our fantastic residents, who is a fellow of the West African College of Surgeons, a very diligent one she was, and she's now in the United States of America, in Chicago, am I correct? Making waves as one of the best in residency in US. Can you just say something to us, a word of advice, please, Laura?
Yes, oh my God. Oh my God. Oh my.
Yes, oh your God, yes. Your God has figured you out. A quick one, please, a quick one. A quick one, please, Laura. Quick,
Thank you, Ma. I'm happy to be here, and it's a very important topic. I really enjoyed the topic, Dr. Daffy, and I appreciate everyone for their support and for listening in. Thank you, Dr. Briggs, and thank you, everyone.
Okay, so all I want to say is that to you all residents here, please, you've got all it takes. Be the best. And when your thing is good, you are selling. So Laura has crossed over there and she's selling the Nigerian good of having been trained here. And therefore, we've got what it takes in Nigeria, and we are the best. Thank you, everyone, and good night. Thank you, everyone, and good night. Good night. Thank you.
Good night, everyone.